Good morning.
Good morning.
How are you? Yes, so that was a very powerful introduction. I could barely recognize myself, but it's drafted to impress. So thank you for that. I feel very excited when I see these types of forums. Sorry, I did damage my knee a bit, so the orthopedic surgeon was very categorical that I have to do this brace, for 6 weeks, and this is my second week, so I have 4 weeks of walking with a bit of a struggle. So forgive that. Yeah. So as the MC mentioned, she mentioned many things, but I think what is more relevant in this context is I was asked to set up a new state corporation that is specifically established to look at human resource for health matters. And I know David, I've known David for a long time, Dr. Biango, and so I know how passionate he is about matters of young people like himself. I always say that he's a very young person to me. And what that means, and particularly in the context of a fairly complex labor market, which is what the health market is. It's not as straightforward as other types of markets. It's a very complex market. So when David asked me and we were talking about this, I think he did tell me a while back, and I had been traveling quite a bit, so that got lost. But when he was reminding me yesterday, I was wondering, so what is it that I can mention to these young people? And most of you are working within, either working or training within the health sector professions. Is that accurate? Yes. There are no bankers here or anything, just checking. Yeah, I mean, they're still welcome. At Strathmore, we actually have an MBA in healthcare management program, which I know some of you would be interested in, and I'm being careful because I know I'm just studying in another university, but this is completely related to the topic. And so sometimes some of the people who come to the MBA healthcare management are bankers who have an interest in understanding lending or corporate finance in healthcare. So even when I'm talking about bankers as a joke, it doesn't mean that you're misplaced in case you're a banker. Yeah, so I'm just going to take about 10 minutes to share a few thoughts around what I feel the health labor market looks like, what the challenges are, what the Kenya Health Human Resource Advisory Council is and how it's trying to help. And again, we'll be happy to take a comment or two, if time allows as well. And I like that it's a small group, so it's easier to engage and really listen and ask any questions. Sometimes when I find myself standing in a very big room with 500 people and questions start coming up, it becomes very frustrating. So this is just the perfect size for an engagement meeting. So we've just finished doing a health labor market analysis for Kenya. It's not been published yet. We think we should be able to launch this in the next 4 to 6 weeks. A labor market analysis is a very important tool when it comes to planning for the healthcare workforce, because as you know, the health sector has multiple professions, multiple specialties, and it's also very complex. Public sector, private for-profit, private not-for-profit, community, primary healthcare, specialist services. It's a very complex market. So we've never done a health labor market analysis before. This is the first time we're doing. It's something that is supported by the World Health Organization. So we work very closely with them as a Ministry of Health. And it's actually revealed some very interesting facts. Some of them I'll share as I continue talking. But what struck me, so I know you may not be familiar with the health labor market analysis and what it looks like, but if I break it down in very simple terms, it basically looks at the entire ecosystem worker perspective. What is the production of the health workforce? What is the need in the market for the health workforce? And then what is the demand for that need? There's a difference between need and demand. Who can tell me the difference between demand for health workers and need for health workers? Any guesstimates? Any educated guesses? What's the difference between demand for health workers and need for health workers? Come on. You didn't go to village schools like the rest of us. You should be able to. Some of you look like you went to fancy schools and academies. This is English actually, guys. Well, a little bit of economics, but there's a bit of English. Thank you.
Good. Need is, I can say, for example, that WHO will say we need 10,000, like one nurse for every 10,000 patients. So that is the need.
Right.
So you put all the population in Kenya and say, maybe now we need, with our population, we need 50,000 nurses. That is the need.
I like that. Go on.
But now the demand is now the uptake. Let's say the county government of Busia I come from, we say we only going to take, even though we need 50 nurses, we're only going to take 10 because that is what we can afford.
Oh man, give that man a slice of a cake. Or maybe for a man it should be something different. Men are not as fascinated about cake as ladies are, so maybe we need to give him something stronger. Yeah, but he's right. Demand is basically expressed need. Yeah? So demand is both a function of the fact that you need, but there's also arrangements that allow you to absorb, including money, including working schemes, what we call the human resource for HR instruments. So you can argue in the labor market, demand is such an important parameter because, and this is something that comes up a lot, particularly in some of the forums that I sit in with fellow healthcare workers. Because I am a healthcare worker primarily. I'm actually a pharmacist by background. And before I went into health systems and policy, which is what I do now, so I relate to healthcare workers as well. Yes, so thank you for that. That was spot on. So demand is ability or willingness to hire. It's not just the need, but the fact that you have everything that allows people to be absorbed. So that's what the health labor market looks at. So I said it looks at production, it looks at demand and need, and it also looks at mobility, including attrition from the health workforce and even migration. Right now there's a big discussion around particularly nurses' migration to other countries. So we've looked at all that. It's in a report. I cannot share that report because it's about my pay grade. But as soon as you see our cabinet secretary launching a report and ribbons being cut, I'll be more than happy to share with David very quickly so that you can have access. Governments have protocols on how things are shared, and that is one thing some of us from the private sector are learning. For us, once information is there, you want to put it out very quickly, but sometimes you have to. Some interesting things came out of the health labor market analysis. So, the contribution of the health sector to our GDP or our economic performance is fairly low. It's still quite low. You can debate about how it's measured, but we contribute only about 2% to the GDP, and that seems to be reducing. Although the private sector seems to be playing a bigger role, which basically means as a healthcare worker or as a manager who is managing healthcare workers, you need to know that the private sector is growing faster as an employer than the public sector. And what does that actually mean? We'll come back to the reflections about that. We also found that we have about 190,000, just below 190,000 active healthcare workers in Kenya. That's a fairly decent number for an African country, but we're still below the numbers that we need. Out of the 190,000 healthcare workers we have, about 75% are in active employment. 25% either unemployed or underemployed. Okay? So if you're a nurse or a physiotherapist or a doctor and you're running a pesa shop, you're underemployed. Okay? So the statistic of 25% being underemployed is a big worry to us. Because it also goes back to, sometimes we think we have a problem of production, but are we actually checking them up in the right spaces? Don't worry, I won't give too many more stats, just a few more. That was quite interesting. We also picked that the distribution of healthcare workers is very skewed towards, I think it's something we know, but we actually quantified. It's very skewed towards urban areas and areas that are known to be attractive, particularly the younger healthcare workforce, which is ironic because I would think younger people tend to be a bit more adventurous and more willing to go to new areas to create opportunities. But apparently, you people in this room don't want to go to Baringo and Isiolo and Tana River, and I'll come back to that. But what I've found from experience is sometimes it's easier to create an opportunity for yourself in a difficult environment than to compete. In business schools, we talk about competition, the different types of market strategies for you as a business. So there's what we call the red ocean strategy, which is basically competing, in a crowded market. So a lot of people here prefer the red ocean strategy. You have the blue ocean strategy, which is going to a new area and creating a niche for yourself. The interesting thing is blue ocean is preferred to red ocean, because red ocean is a terrible market. It's what you call a race to the bottom market. So people will successfully continue underpaying you because the labor market is flooded. Your value will not be as appreciated because you are replaceable with the person who's basically standing behind you. Whereas for blue ocean, it's a totally different situation because it basically means you found yourself in a county or in a region of Kenya where your services are greatly needed and appreciated, and you demonstrated your value very easily. I'm not saying it's easy. I'm one of the young people who did not want to go to the rural area, so this is not a judgment in any way. It's just a reflection where I am. Steve Jobs says you can only connect the dots looking backwards, and that's what I'm doing now. So I'm talking about this. I graduated. Now it's actually hitting me. I graduated almost 20 years ago. I graduated 18 years ago. So I've been in the market for a while. Yeah. So I'm trying to connect the dots looking backwards. That's what I'm trying to do. All right. Yeah. The other distribution challenge that we saw, and this is related to the skillness, is we have a lot of problems from one county to another. That's a major issue. The best serviced counties for human resource are 7.3 times better off compared to the worst counties. That basically means Nairobi is 7.3 times better off in terms of having the numbers that it doesn't even need, compared to Kilifi. And that is another reality. Okay? So what does that mean? It basically means there could be opportunities here, but you never find them because of how the distribution is skewed. Now, based on these, so the third thing I said I talked about is the Kenya Health Human Resource Advisory Council. People are asking, who are you and what are you doing? So the Kenya Health Human Resource Advisory Council is established under the Health Act of 2017 as a state corporation to look at matters of human resource for health. That's all we do. Yeah? If you have an understanding of health systems and how they're structured and how they function, you know that there's basically three foundational pillars that determine how a health system performs. There's the people, there's the money, and there's the products, supplies, and everything else. Yeah? Now, those now require leadership, require information and everything else. But the three core components are the people, the money, and the supplies. Okay? So the money is handled by the National Hospital Insurance Fund, NHIF. So there's a state corporation that handles money. It's called NHIF, which is being repealed over the next 12 months to be replaced by the Social Health Authority, which is coming up. Okay? The products or commodities are handled by KEMSA. So there's a state corporation that handles products. It's called the Kenya Medical Supplies Authority. So it handles everything to do with health products and technologies. What was missing was a state corporation to handle people. So that is what my state corporation handles, the Kenya Health Human Resource Advisory Council. So we're basically set up with a mandate of ensuring that the human resource for health function works, because it's the only way we can then achieve universal health coverage. And reflecting back to some of the challenges that we found from the health labor market analysis on the production, the first thing that we are doing as a council is we are trying to create a better alignment between production and need/demand. The counties are complaining a lot that healthcare workers are clamoring for employment, but there's a mismatch between what they need or what they're demanding and the numbers that are being pushed out of training institutions. We are trying to correct that, and we're working with the Ministry of Education. I think some of you have seen the new funding model for universities, and some of you might have heard the president echoing that sponsorship for regular students is now, we are trying to make it better aligned to the need and the demand. So if you go for a course that has a higher demand or need, then you are more likely to attract the government's sponsorship than going to one where the need is low. Okay? So that is a way of tinkering with the labor market so that you stop healthcare workers from getting frustrated, because then you're going into a course that doesn't give you the opportunities, and B, it also protects the employers, who are the county public service boards, the Ministry of Health, the private sectors and others, because they tend to be on the receiving end of the health labor unions, because the unions are constantly pushing for their people to be employed, not really thinking a lot about, and this is, I engage a lot with the unions, and one of the things that we discuss with them is we just need to make sure, even as a union, when you're pushing, you need to make sure you're pushing the right colors. So that's already being worked on, and it's part of a declaration we're working on. The other thing we're trying to do is to roll out a new methodology of understanding the demand and the need. And this is called the workload indicators of staffing needs. We call it WISN, the workload indicators of staffing needs. At the moment, we've been using a very old method that WHO introduced, which is you need one nurse per X number of people. You need one doctor per X number of people. It's a very, I don't want to say it's useless, but it's not a very useful parameter. And you cannot use it to ask for resources, for example, from Parliament, because that is what we are constantly doing. You have to constantly engage in Parliament committees to push for resources. So if you go to Parliament and you tell them that our ratio is one doctor to 15,000, one nurse to 15,000 Kenyans, and it's too low, I want money, they'll just be looking at you and they'll be waiting for you to get out of the room, because it doesn't mean anything. So we are rolling out what is called the workload indicators of staffing need, because this actually quantifies the work that is there and the number of people who are there. We basically map the journey. You develop the journey for a nurse. What does she do when she enters the hospital? She sees X patients. How much time does she spend on each patient? If it's dressing, if it's triage, it doesn't matter what you're doing. So you quantify that, and then we do that statistically, through a statistically representative sample, and then you should be able to tell Isiolo County Referral Hospital has a shortage of 17 medical officers, 120 nurses. Now, those numbers are not some statistics from WHO figures. They are real numbers that point out the risk of patient safety, because one nurse is supposed to be spending X amount of time doing triage. Maybe she's supposed to spend 3 or 5 minutes doing triage. They are spending 30 seconds because of this. It's easier to engage with people who give money when you have that level of detail. I don't know whether that makes sense. So that's the other thing we're trying to do as well, as the Kenya Health Human Resource Advisory Council and the Ministry of Health. The other thing we're trying to do is to, and this is a major fight, we're trying to push for post-internship. So first of all, we're trying to regularize internship for all healthcare workers, because there are cadres that are disadvantaged. I think doctors, perhaps it's a bit more structured, but if you go to, there are cadres where the internship is not paid and it's not well structured. So we're trying to standardize so that some professions don't suffer while others, because as far as we are concerned, as a Human Resource Advisory Council, all healthcare cadres are the same, and they all need to be treated, they all need to be elevated and treated in the same way. So we're trying to standardize internship so that it works across. And the other thing we're trying to do is we're negotiating with the Treasury and leadership within the country to try and have all interns have a mandatory 2-year contract after internship, so that they gain some experience before we release them to the labor market. We think that releasing somebody immediately after internship is very punitive because they don't have experience. And it's very hard to get a competitive job with internship on. Most people want you to have at least 2 years post-internship experience. So we are trying to get sort of the government commits to employing people for 1 year internship and then a fixed 2-year contract post-internship. And after that, they release you to the labor market to compete, to fight like everybody else in the red ocean. We think that makes more sense, because even from a labor migration perspective, it's very difficult to get a job in another country and travel without at least 2 years of experience. So by giving everybody at least 3 working years, 1 year internship, 2 years experience, it means that even if you can't get a job here, you can consider getting a job somewhere else, because you have been adequately prepared to be competitive. Of course, there are challenges with that. One of the challenges is, and are there any interns in this room, by the way, or not yet? So then, okay. Which area? Sorry. What's your profession? Oh, you're okay. You're a pharmacist. Yes, I'm a pharmacist. Oh, and you're too good. So the rest of you are mostly, sorry, pre-interns. Oh, that's like pre-teens. Yeah. Anyway, so one of the challenges we have is, the wage structure for internship is fairly decent. It's quite good, and that is a good and a bad thing. Now, I'm approaching this from the health labor market. Okay? I'm not approaching it as a healthcare professional. One of the challenges we are having in this negotiation is people who are not in the health sector think that the internship payment for people in the health sector is too high. And the way government works is you can never reduce somebody's salary. So that is proving to be a major barrier for us. Somebody is saying, if interns are earning 200,000 Kenyan shillings, or just slightly below that, and you want us to employ them, everybody who does internship, I'm talking about doctors, for example, and you want us to employ them for 3 years, where is that money going to come from? That is what we are being asked. But if they were earning 100,000, then it becomes an easier conversation. I need you to understand that policy can actually be very tricky. Sometimes a success on one side can actually become a barrier on another side. And unfortunately, you're talking to people who have to allocate resources to roads, to the environment, to the lakes. So these people, they don't share the passion that you have for healthcare. They just see you as a, welcome Dr. Liz. They just see you as a, as an agent in the labor market, just the way they see a lawyer, just the way they see an architect, that's the way they see an engineer. That is how Treasury looks at resources and allocation. Yeah? Liz, in fact, when you're coming in, I was just talking about something that you might be interested in, because I know you're a board member in the Kenya Medical Association. So one of the things that KHRH is trying to do is to negotiate for 2-year post-internship employment of all healthcare workers to give them experience. But the challenge you're having is the salary structure at internship is too high. So I was telling them that success on one side becomes a barrier on another side. Yeah? And when we tell them that a lot of these people are struggling and they would not actually mind having half of that salary guaranteed for another 2 years, they tell us that government does not reduce salaries. But when you talk to the young people, when you talk to the interns, they actually tell you, I take it. I would take 100K for another 2 years of a fixed contract. I would take it. But now when you go the other side, the other people say, no, we'll be going against the workers' rights. So why can't I determine my own rights? So I'd rather be jobless. Like jobless is a better option. Where do rights come in? You understand how complex some of these conversations are. Okay? And actually one of the things I will be proposing to professional associations and unions very soon is a very unpopular thing, which is having a conversation with their members about potentially reducing internship payments. It's a very difficult conversation, but I can tell you for a fact that is the reason why there's a glut in employment. And that's the reason why we are having a problem getting everybody to get the 3-year contract. That's just the truth. Okay? It's just the truth. But how do you tell somebody, especially who has not gotten there, that I'm negotiating to reduce your salary, even if you're a union? I mean, how do you even do that? I've started this conversation with some of them doubting and talking about it, and they dismiss it very quickly. But I tell them, sometimes you just need to be very honest with your members and tell them that this is a situation. We've priced our people out of the market. That is the truth. It's not ideal, but we've priced them out of the market. What are we supposed to do in that situation? So it's basically being between a rock and a hard place. Now, I don't know how I was earning 40K when I was an intern. And immediately after that, I moved, I think, to 68K or something like that. And I remember how exciting it is when you move from internship to a higher level. You know, that sense of growth. So do you want to deny people that by negotiating contracts that remove them here, then they start working here? So it's a very difficult situation. The reason why I'm being very honest with you is I genuinely believe if people really understand the challenges that are there in the labor market, you're more likely to make a realistic argument. And you can even the way you engage with your leaders and with your profession, it becomes more realistic. As somebody who mentors a lot of young professionals, and I work with them, I interact with them. Some of them are my family members. My small sister was a medical officer for quite a long time, and I saw the struggles she went through, being exploited, doing locums and not being paid. If somebody had told at that time that I'm giving you something that guarantees you 100,000, she would have had that person. Because the truth of the matter is the labor market is very tough. So how do we deal with some of these situations realistically? We'll have to go against what we are not used to. So that's what we're doing. The last thing we're trying to do, I realize it's 10, which is my time is over. The last thing we're trying to do is, and this is also another major challenge, mobility of healthcare workers. When health was devolved, and particularly the public sector, it's become difficult for healthcare workers to move from one county to another. And that can be a very big problem. You're told to resign and then go and apply for a job. But when you resign in your county and you go to the other county, and especially if your last name is a bit different, you may not actually get that opportunity. That is the reality. I don't like saying it, but it's the truth. But then I'm going to be very honest with you guys. the time for sugarcoating is over. We need to really try and protect healthcare workers now. And doing that requires us to have very honest conversation. Sometimes when it comes to matters of employment. So what happens if you need to join your wife, you're working in Marsabit and you need to join your wife in CI? There's no mechanism in place. You have to resign in Marsabit and then come and apply in CI. That is very punitive to our healthcare workers. So we're coming up with a mechanism that will allow transfer or exchange of staff across different counties. And there's a group that's really focused on making sure that works within the next 6 months. The reason why we're very interested in this is we think a healthcare worker who is not happy with the environment where they cannot deliver. They'll just be getting by. They'll just be doing the minimum to make sure that they get by. The other thing that's related to mobility that we're trying to work on, and we are working with the Ministry of Labour and the National Employment Agency, is the health worker migration. And making sure that our healthcare workers well informed about the options they have in terms of migrating to other countries. Outside the UK, the US and Australia, people know very little about opportunities that exist in other markets. There are even opportunities in Africa. How many of you actually know that? Okay. So we're also trying to work to create that. And there's actually a policy in draft. It's under development on health worker migration that's going to really guide us on how we inform and how we support our healthcare workers. I think 25% underemployment or unemployment is too high for a country that does not have enough healthcare workers. So if their market cannot absorb the 25%, we need to give our people, our healthcare workers, a fighting chance to go outside and explore some of those chances. And that is one of the things we're working on. And at the moment, it's mostly been nurses and maybe a little bit of doctors, but now we're even trying to look at, so for example, the bilateral agreement with the UK is trying to look at what other cadres can we have opportunities for them to go and work there. Because it doesn't just have to be about nurses. Okay? So we're looking at all those so that we also open up these opportunities for healthcare workers. So I'll stop there, and I hope that through my honest submissions, I've given you a view into what the health labor market looks like and how difficult it is to maneuver and make decisions in an environment that is, where people are competing for very limited resources. Thank you very much for your attention.
Thank you. So, thank you for that pre-submission as well. For the members who are here, anybody with a question?
Hi everyone. My name is Derek Bundi, and my question is, we are experiencing what people might perceive as brain drain, similar to the AHs, especially with healthcare providers. And at the same time, we've pointed out that there's a mismatch in terms of there's a healthcare gap, healthcare workers gap in our counties. So how do we ensure that we are able to serve our population and at the same time ensure that this 25% that is unemployed or underemployed is getting opportunities? Like, how do we, where's the balance?
Yeah, that's a very tricky question. Huh? So the thing of brain drain, sometimes the media sells it in a very sensational way. It can be very misleading. Globalization means the labor market is going to continue being fluid. If you're a developing or a lower middle income countries, we don't use the word developing countries anymore because it's not politically correct. If you're a low or middle income country like Kenya, should you really be worrying about things like brain drain? Again, it's not a very easy question to answer. On one end, you have 25% underemployment or unemployment. On the other end, you actually need these people. Now, brain drain is a double-edged sword. On one side, No, our largest foreign exchange earner for last year was actually, I think, remittances from abroad. So our people going to work abroad is good for our country. It's what props us up. Right now the dollar is beating the shilling senseless because of the remittances going low and all the challenges that we have. So even as we stick to our people and say that we want them here, they're not getting jobs because the dollar is getting weaker, and part of the reason is they're not going out. You can see how complicated all these things are related one way or another. But on the other hand, some of the brain drain is actually a real issue, including where very senior and experienced people are living. So I always like to say that let's not use one word to define brain drain. We should actually encourage some people to go. That's my honest view. But we should find a way of protecting the cadres and the specialties and the people who need to be here, because otherwise, who's going to be providing specialist services? So we need to find a balance. Now, the Kenya-UK bilateral agreement was very clear that the UK government is not going to take a Kenyan nurse who is employed. They are very clear about that in the contract. Okay? So you have to be jobless. But now what is happening? Very senior nurses in KHRH and other hospitals are resigning and applying. So at the time they're applying their job, they're jobless. But the hospitals have actually lost a very senior theatre nurse. So that is the bad side of brain drain. And from a contract perspective, there's very little that you can do there, because you cannot force somebody to work against their will. It's not how labor markets work in the world today. So that's what I'm saying, it's a very complex thing. And what countries like Philippines and India increasingly are doing is they're focusing. Is it easier to train or is it easier to employ? It's easier to train, isn't it? So Philippines actually have an entire value chain. They even schools that just train for export. They're not even doing it for the local market. And the process is so seamless all the way until you settle in the UK, Australia, US, or Canada, wherever you're going. You get. So is that a direction we should now take? Should we be realistic enough to actually say it's easy for us to train? In fact, we overtraining. We are estimating that between now and 2031, we'll be adding to the labor market over 8,000 healthcare workers. And this is after adjusting for attrition. We are going to be adding 8,000 healthcare workers. The real number is higher, but we are adjusting for attrition. We're going to be adding 8,000 healthcare workers every year between now and 2031, according to the health labor market analysis. Where are they going to? You get. So should we just be conscious and actually admit that we have one of the largest training colleges in Kenya called KMTC? We have some of the best universities here, and we are very good at production. Can we just invest in production so we become a production company? Not a country, a production company. And then we produce for specific markets. If this is what the Qataris want, if this is what the Emiratis want, if this is what the Canadians want, if this is what, and that is what the Philippines do. Okay? So that is why they are very good at exporting all these healthcare workers, and it has really built the economy. It's easier for us to produce because we are very good at training. And Kenyans are very educated and they want to learn. And we have a very big youthful population. So the fundamentals favor production. But our economy is not large enough to absorb everybody. So maybe it should be a strategic decision to take as a country. Set up certain institutions that are specifically, and I actually did challenge the CEO of KMTC, Kelly, Dr. Kelly, I told him, maybe one of the things you should be thinking about, actually I think I was telling the Deputy CEO, Dr. Nyawira, I was saying one of the things you should be thinking about is have specific campuses that are specifically training for export. And then you have the Canadians coming to assess the campus. They actually say, this is how we train your physiotherapists or occupational therapists. Do they meet our standards? They do. So each time you train, we go there directly. That is a way of increasing opportunities for healthcare workers. I hope that answers your question. Yeah.
Thank you. Two more questions.
Hello, my name is Tisha. So I have two questions. First, you had mentioned implementing pay cuts for interns, right? which raises an eyebrow because of the rise in cost of living.
Yeah.
Right? So my question is, how can we ensure that we hold the state corporations accountable, that the money is going to be redirected to improving the healthcare systems, to ensure that there's procurement of medical supplies, and to ensure that the facilities are improved? Because usually you find that a lot of these state corporations will come and say, okay, fine, we're going to cut the cost, but the healthcare systems are not being improved, the facilities are still the same, there's no medical supplies in these facilities. So how can we hold these corporations accountable? Second question is that you mentioned that there is a distribution problem within, but mostly that there's a lot of employment opportunities in Nairobi and not in the rural areas. In Canada, for instance, they have incentivization for healthcare workers, where if you work in rural areas, you're given a financial incentive. So what strategies are being employed to incentivize healthcare workers to work in rural areas and under marginalized communities?
Well, thank you. Again, those are very good questions. I'll start with the second one. When health was devolved in Kenya, we used to have some incentives. They were not good enough, but I thought they would have been improved. But when health was devolved, suddenly we had 47 governments. And so what was a rural area at national level suddenly becomes a whole county. You get where I'm going with this? So that categorization of hardship, etc., was kind of dissolved. Because under the national system, Baringo was maybe a hardship area and you get an allowance, which could have been improved over time. But now when Baringo becomes a county, you get. So that's the challenge that is why we lost that. And the county public service boards are trying to bring that back. Actually, we had a national dialogue, a human resource health national dialogue sometime last month. And one of the things that was discussed during that dialogue was we need to start incentivizing people to go and provide services in areas of high need. The incentives don't even need to be money. Money is important, but they don't have to be money. It needs to be, can you provide amenities that allow them to live there? Can you even partner with people to make sure there are schools that can actually, their children can go to? Security is an issue. You don't want somebody going in a place where they're not feeling safe. Can you look at what makes a place livable and then start encouraging people to go there? So I think they're working on that. They're not figured it out, but I know it's something that the chair of the county public service boards mentioned. The first question is a very tricky one, and I don't have an answer to that. I think what you're asking is quite often when money is set as money, pesa inafanana, government money looks the same. So what you're saying is, if an intern salary is reduced from 200,000 to 100,000, how sure are we that it's actually going to support the employment of others? That's always a tricky thing. So the way these contracts are negotiated is, it has to be this and this. You don't care about the money. If you start talking about money and following money, you'll end up in a rabbit hole. So the smartest thing you can do, welcome Dr. J, the smartest thing you can do is, if the unions are there, and one thing the healthcare workers have are very strong unions. I deal with those people, they're not easy. So they're very good negotiators. So if the unions have accepted to have their members' pay reduced, then as a prerequisite to sign up to that, the government needs to accept to employ them for 3 years. That's the only thing that will work in government. Don't follow the money. Just make sure that people will remain in the payroll for 3 years. They'll be paid. Okay? That's it. But it's very hard to follow and say that this is dedicated money and it's supposed to be going to these costs. It becomes very difficult. Because governments have just a way of collecting money and spending it else. I hope that answers your question. Yeah, but it's very difficult. There's no fixed way of approaching that. I think there was one last question, if I'm not sure.
One of the things that we really hoped was that health, especially the human resource, will go back to the national government. But now that you're there as an advisory committee, what is the possibility of that, or what are the challenges that you encountered, or is it something you considered?
Yeah, that keeps coming up. It comes up all the time. And I actually have a KHRH board member here, Dr. J, who's just walked in. She's actually the vice chair. And, so this is a difficult one. Maybe you can also throw that to her at some point. But the bottom line is, health is not even an evolved function. People say that wrongly. Health is actually a shared function. Okay? It's just that by virtue of counties being responsible for primary health care and primary hospital services, they have the bulk of the healthcare workers. That is why people wrongly say that healthcare is evolved. But the truth of the matter is, healthcare is a shared function. Now, the question of whether healthcare will be decentralized through a health service commission is a political question, it's not a technical question. Yeah? And I want to say it's beyond my pay grade to talk about that. But since I've been very honest with you throughout these conversations, I might as well continue being a bit straightforward. I think as healthcare workers, pushing for that agenda is backing up the wrong tree. That's my honest view. I think it's backing up the wrong tree, and what it's doing is it's causing a lot of suspicion and pushback. It took 6 years to form this Kenya Health Human Resource Advisory Council from the time the Health Act was passed. Why did it take 6 years to form this body? It took 6 years because the county government thought that this body is a backdoor re-centralization of healthcare workers. Just a suspicion. If you actually read our mandate in the law, it doesn't talk about re-centralization. But just a suspicion that we could be coming to create a health services commission to reset, just a mere suspicion led to this not being formed for 6 years. Okay? That's how touchy this subject is. Now, on the other hand, there are certain aspects of health services which could be managed better through either independent entities or in a more national level. My view has always been, let that be an organic process. Let that be something that comes over time through negotiations as people work together in good faith. What healthcare workers cannot do is take to the streets and say that health should be decentralized. That is a very bad idea. That's all I can tell you. And I can tell anybody else who cares to listen. Because that requires a constitutional amendment. One of the things that was mentioned to us, and Dr. Joy will remember this because I think you are part of the meeting. So the Kenya Human Resource Advisory Council had a meeting with the Council of Economic Advisors, the President's Council of Economic Advisors, Dr. David D and his team some weeks back. And one of the things that he said, which resonated very well with me, was healthcare workers want a health service commission. They want health service decentralized. But have they asked themselves, what are those functions? What are the things that they need done? And can those things be done without going through that complexity of changing the constitution? And his argument was, yes, a lot of those things can actually be done through good faith and negotiation, including sharing healthcare specialists, including transferring or allowing staff to move from one county to another, including standardizing payments. All these things can actually be done. But if you want to go through a constitutional amendment, then what happens is other politicians jump on and they start putting other things that make the whole process very toxic. And then you end up with another, what was it called, BBI and other things. And then it falls on its face. So instead of trying to go that complex route of changing the constitution, why don't you as healthcare workers sit with the different groups and actually say, Teacher Service Commission does these 10 things. Can we have these 10 things also being done one way or another without creating a body that's called a Health Service Commission? Because as a healthcare worker, you should not worry about what it's called. You should be worrying about whether it's serving you. So our argument is always, let's avoid very emotive topics. Let's avoid these things that create a lot of disharmony. And let us focus on the functions. What is it we want? TSC functions the way it does because it can post a teacher to a place of need. Can we actually have KHRH or the Ministry of Health or any other organs playing that role? TSC does what it does because it has standardized the pay grades. Although more recently we've actually learned that that's actually not true. There are teachers who have not been promoted for 20 years. People are getting shocked to hear those things. we used to think it was a very seamless process. So even as we admire that system, we also need to know it's not perfect. But if what we want as standardized job groups, can we actually get that embedded as well? So allow me to stop just because of time, and I've seen my colleagues have come in as well. But of course, through David, I'm happy to continue engaging to respond to specific questions. Thank you very much.
Thank you so much.